What an insightful session by Catherine. The future seems to be dictated by health tech, and that is going to be our reality. At least that's what my prediction is at this point in time. Ladies and gentlemen, what we have for you now is a very interesting panel discussion on lessons learned in the implementation of EHR in LMIC countries. Moderating this panel will be the very learned Mr. Shaukat Ali Khan, and the panelists will be Carl Amerhin, Howard Messing, and Arsalan Hashmani of Hashmani Group. Without further ado, let me call upon Mr. Shaukat Ali Khan to begin this insightful panel discussion. Stay tuned, there's a lot more coming up.
Welcome to you all today. Thank you for being with us for this discussion. My name is Shaukat Ali Khan, and I'm the Global CIO of the Aga Khan University. I'm joined today by my colleague, Professor Dr. Carl Emmerheim, Provost and Vice President Academics, the Aga Khan University, Howard Messing, Vice Chairman of the Meditech Board and former CEO of Meditech, and Arsalan Hashmi, Group CEO, Hashmi's Group of Hospitals. Our panelists have a wealth of experience in patient care and the use of electronic health records to develop efficiencies and improve outcomes for patients. We at the Aga Khan University are especially pleased to be partnering with Meditech in rolling out electronic health record across our centers around the globe for all our patients. Today, I'm looking forward to hearing from our panelists on this highly relevant topic, in particular, the challenges of this approach and lessons learned from their experience. Let me start by inviting Carl, Howard, and Arsalan to share their backgrounds and what brings them to their roles today. Carl, you have been with AKU from the last 5 years now. After charting a successful path, please share the highs and lows of your career and how this has shaped your perspective on today's topic.
Thank you, Shaukat, and good day to everybody. It's a big question, highs and lows after 30 years in the academic business. Perhaps relevant to the topic of today, the high point when I was provost at the University of Alberta was when we took through the governing and funding process a proposal that made wireless access at University of Alberta ubiquitous and free, and that 50,000+ students and faculty and staff in several locations all of a sudden had all the access to the internet and all the access to central computing that they wanted. Probably the low in my computing career was as a very young academic, and we'll see how many people recognize the words. I was a quantitative geographer. I did some very early work on global positioning systems, and I was modeling on a Cray supercomputer. I think Howard probably remembers Cray supercomputers. And I inadvertently mistyped something in my Fortran program. Some of you may remember Fortran. And I ended up crashing the Cray supercomputer, and the computer people threw me off the computer and put me in the computer dungeon for a week to teach me to take better care of my code. So that was probably the low point, but I recovered from that. So what brings me today is a career starting in 1980 as a graduate student of always trying to exploit the cutting edge capabilities of technology wherever it was to be found in whatever category, including work to finance and install an electronic health record system in a provincial health system in Canada. So back to you, Shaukat.
Thank you, Carl. I think you have an inspiring and impressive career, and we at AKU, we are very lucky to have you here. Howard, You have been the chief executive officer of Meditech, so it would be great if you can share your vision when you were the CEO and now you are on the board. How it is being realized and what can we learn from this and other roles you have held?
Sure. I've actually been with Meditech for my entire career, 47 years, and I've seen quite a bit of change.
Just to hold a second, Nazish, can you please mute yourself? Seems like there is interruptions coming. Nazish. Thank you. Sorry, Howard. Yes, please.
That's fine. That's fine. So as I started to say, I've been with Meditech for a long time and seen the growth of electronic health records from being sort of auxiliary systems to really the heartbeat of healthcare organizations. Carl told a low point in his career. I'll tell one. I don't know if it's a low point, but it's relevant to this and I think interesting. My first visit to Pakistan was actually in 1986. I actually have a picture of myself in the courtyard of the brand new Aga Khan University Hospital. If you look at that picture, you know it's old because I still have some hair in that picture. But the other interesting thing about that picture is there was no one else in the courtyard but me. If today you go to that same courtyard, it's full of a lot of people. So it shows the growth there. But an interesting story from back then and a low point, I was very proud. I was a programmer at the time. And I was very proud of a program I had written in the United States to help people in the entering of patients' names. And it was quite a shock when I came to Pakistan and understand that there aren't many Smiths or Jones in Pakistan and that algorithm wasn't going to work very well when many of your patients had the name Muhammad. So I had to do some very last minute programming to make that work. In any case, I've seen the growth of electronic health records. Back when I got started, very rarely did I ever meet the upper management of healthcare organizations. We were a backroom system, mostly doing things like payroll. Today in time, as I said, the healthcare systems really need our software, need the entire healthcare record. And we're very proud to be part of the effort to bring a modern system to Aga Khan University's hospitals. And I'm interested to hear what my co-panelists have to say about the challenges they see. I see a lot of challenges, and I see an organization that is meeting those challenges very well.
Thank you, Howard. Arslan, you are a young executive with excellent academic background. I was just looking at your profile, and it's very impressive. Can you just tell us a little bit about your journey so far? Can you unmute yourself, please?
Yes. Hi, so greetings everyone, and greetings Shaukat. So I've been with the Hashwani's group of hospitals for the past 7 years now. I see electronic health records or in general, any IT system per se that would be implemented at healthcare institutions as playing a vital role in today's day and age. And we've seen COVID sort of help us accelerate the implementation and the adoption. So in terms of the highs and lows that others have shared so far, I'll share a low with you. And that was, I was a part of a team implementing a chronic disease management system in the province of Ontario in Canada. And the big challenge there was that the project was above budget and going beyond time. And the actual reason for that was trying to ensure interoperability by bringing on board doctors and clinicians and providers across the province to input all the data into the system. And so managing that change from where they were doing everything manually to now doing it digitally, that adoption was taking us time, due to which the project essentially was over budget and over time. So that's a low. And in terms of the highs, like I said, COVID helped us in particular adopt technology at a rapid pace because that was demanded by the patients of the time. So when we rolled out vaccination program for COVID particularly, we were one of the first institutions to start the Sputnik vaccinations in Pakistan. And so when we did that, we had to ensure that the entire process for the patients was seamless, from registration to getting their vaccinations done, to getting their reminders, to ensuring that they get the second dose done on time. And that was just a very proud moment for me and my organization, that we managed it very well, to the effect that we had very, very minimal patients that had to go through the second dose beyond the prescribed limit.
Thank you, Ruslan. The wealth of learnings from all of your experiences is incredible. Let us now dig deeper into some key challenges in the implementation of electronic health record in low middle income countries like Pakistan. So I will start with Carl. Do you find that you have adequate human capacity and talent to effectively implement EHR? If not, then how you address this?
Most of my career, the first 25 years of my career, have been spent in Canada. So I compare my work in our countries, and for the benefit of the audience, we are imagining that the Meditech Expanse system first will be turned on in Nairobi in the next little while, then Karachi, then sooner or later in Kabul, Afghanistan, Kampala, Uganda, Tanzania, Dar es Salaam, and 3 other locations. And then we'll see. The goal is to put the entire healthcare system in the Aga Khan Development Network onto Expanse. And currently we see somewhat over 3 million patients a year in all of our facilities. So it's a tall order. The answer, Shaukat, to your question is that compared to Canada, no. We never have enough high quality, sophisticated, experienced ICT personnel. And it's the condition of our world, the lower middle income countries of the world, LMICs, that we are constantly looking for talented people. We are constantly fighting to hang on to our talented people. And as a university, the corporate entities in our countries, not Arcelon's corporate entities, I'm thinking of the banks, they view us as a bit of a farm team, to use a US sports analogy. And as soon as one of our ICT people get really, really good, as you know, the banks come and offer to double the salary or something like that. Or someone overseas comes to get us. So we're constantly searching, we're constantly hiring, we're constantly training, and we're constantly retaining. So that's a very nimble, constantly evolving environment. The good news is that we do unbelievable things nonetheless. In my work in healthcare in Canada, we in our LMIC countries are doing the very same things that I was responsible for in Canada. So despite LMIC, despite all of those challenges, we can be among the best, the cutting edge. We chose the Expanse system because, in our opinion, it was a very, very modern software system. And it was a software system that our ICT people recognized. They understood the core programming. And it, in our opinion, allowed a very nimble and flexible installation. Every place, Karachi, Nairobi, over into the uncharted realities that represent Kabul, Afghanistan. So never enough, always on the hunt, but we always manage to get the job done nonetheless. But it is exciting. Every day it's exciting, as you know. Over to you.
Yeah, thank you, Carl. Yes, I echo what you said, that there are challenges, but of course we are doing our best based on the available resources. So just to take this forward, question to Howard, as a vendor, are there any challenges to being the first in a country or context to implement a global recognized best practice EHR system? From the vendor point of view, of course, there are challenges from this side of the world. But when you see as a vendor who is implementing this for the first time in the country, a globally recognized best practice EHR system, what are the challenges do you see from your desk?
I think there are a lot of challenges in coming to a country for the first time. From the vendor's point of view, as much as we know about our own software, we don't necessarily know as much as we need to about how healthcare operates in a particular environment. So when we first come to Pakistan or first come to Kenya, our people have to learn the differences between what we're used to in our main markets of Canada and the United States and some of the other countries we do business with. And we need a lot of local help to do that. Particularly in areas that are touched, let's say, outside of the healthcare environment, so that Carl can try to set up the Aga Khan University to use best practices for nursing care and medical care, but there are lots of exit points from the system where you're either paying payers, you're producing reports for the government, you're giving instructions to patients. Those are very local and very specific. And we as a vendor don't necessarily come into a new country knowing that. Now, having said that, once we do learn, we hope to be able to capitalize that and spread that word around throughout the organization and any other places in the country.
Thank you, Howard. And then I would just ask, because this is from the vendor point of view. So, Carl, are there any challenges to being the first in a country or context to implement a global recognized best practices EHR as a first institution in this region and also in East Africa?
Oh yeah, lots of challenges, but not really the challenges that somebody sitting in a first world context might expect. We have supply chain challenges, we have currency challenges. We have those all day, every day, so that's not unique. The challenges that we face are very similar to the same challenges I faced in my Canadian experience. If an institution has never seen an electronic health record system before, then immediately everybody thinks it's an IT problem. Mm-hmm. It is an IT project, but it is a healthcare delivery challenge. We have redefined our standard operating procedures. We have had to standardize across 5 countries in healthcare where they've never before had any reason to worry about standardizing. We've had to make very, very clear to people, this is not a turnkey system. Our supplier does not turn it on August 1st and then go home and it's ours. It just doesn't work that way. So the challenge is being the first in the country is that the overall headspace of the country among the various professions have never thought this through before. So we go to the Kenya Medical Council. They've never seen the kind of system that we're installing. We go to the Kenyan privacy commissioners. They've never seen the kind of system that we're installing. So these are the things that are first. These are the things that you have to work through as the first in a national setting like healthcare that is very heavily regulated as it is all around the world. So those are the challenges that we're working through. Supply chain, currency, all of that stuff, that's there every day. That doesn't make it unique. Back to you.
Thank you, Carl. We will come back on this in a few minutes. Although we are focused on EHR in this discussion, but my question to Arslan is, but we are equally important is in any digital transformation project. Can you tell us your view on digital transformation in ensuring actually patient safety and improved service, and especially the example you gave during your introduction? Have you used any digital platforms to get the optimization or efficiency around this? So can you just talk about that? Thank you.
Sure. So the organization Hashmani's Hospital is been serving in Pakistan for the past 4 decades. Now the challenge, and yes, we have adopted electronic health record systems, and we are on a digital transformation journey. So the actual challenge then becomes, like Dr. Carl mentioned, managing change. How do you ensure that people who have been with us for the past 20, 30 years of their lives and their careers to now all of a sudden accept this new technology where it's not seen as a pet project or a research project as compared to it being seen as a final product and something that needs to be adopted. So that's the first thing. In terms of what we have or what tools we are adopting right now. For our ophthalmology practice, we have 7 eye hospitals in Pakistan, and out of the 7 hospitals, we have adopted electronic health records for ophthalmology for 3 of the hospitals so far. And the vision there is to be able to provide our patients with essentially an online digital tool, either be it on mobile or web, where they can log in and view their entire medical history in terms of their eye health, their prescriptions, their refraction numbers, and then be able to then integrate and grow vertically from there to be able to then provide them eyeglasses, lenses, home care services, and et cetera, et cetera. So that's what we're adopting right now. In terms of the potential for digital transformation and the benefits that can come out of it, I believe the benefits are numerous. From a better revenue management cycle, as long as you have your EHR linked, synchronized with your back office systems, you can have better cash flows, better profitability. You can have better data to be able to then strategically make better decisions in terms of where to invest and where not to invest. You can have better patient experiences, and better patient experiences then at the end of the day builds a better brand, increases patient foot flow, et cetera, et cetera. So better patient experience can then come from anything from reduced waiting times to having access to their data to having overall a better clinical outcome. So yes, and so to just combine and sum it all together, we are going through digital transformation, and we see the benefits of digital transformation to be numerous. And we're very excited to go through this journey and evolve in this as an organization.
Thank you, Arslan. It's interesting. So, Carl, coming back to you, when we are talking about electronic health record, I think the first thing that comes in mind is infrastructure. Do you have adequate access to the hardware and network infrastructure components you need to make sure that you have a full-blown EHR system installed?
Short answer is yes. We didn't know that we would have access. We placed the order. We ran into all of the supply chain issues, but Aga Khan University is part of the much larger Aga Khan Development Network. And as you know, since you were the conductor of this symphony of machine acquisition, when it looked like our primary vendor was going to run into supply chain issues, we just pulled out all the stops and we went to every supplier that works with AKDN, and in a reasonable period of time, we seem to have accumulated all of the equipment we need. We've had to borrow from our inventories of hot spares, So we've reduced our margin of ICT security or safety, but we have what we need. The other area where we are still in acquisition mode, we've talked a lot about patient care, direct patient care. I'll call it disease remediation. Arsalan put it very, very nicely: safer, better, faster. But for me, the massive payoff for a comprehensive integrated electronic health record system is not just disease remediation, but disease avoidance through the creation of algorithms, what we now call artificial intelligence. And we're not sure that we have access to all of the physical equipment or the algorithms that we might want in the near term to really harvest the benefit of disease avoidance, healthy living. And I'll pick up on Arsalan's example of ophthalmology. Wouldn't it be great if we had all of the machines that eye doctors use hooked up to all of the machines that the diagnostic labs use, hooked up to all the machines that the dermatologists use? And then we had the algorithms to take a look at a patient's history, interrogate all these systems, and look for the early onset signs, starting with parts of the eyeballs, I guess, that are strong indicators of the onset of diabetes. Like in our countries, like the rest of the world, diabetes is going to be a runaway issue. So the machines we need in the hospital were good. But as you fan out, as you imagine the electronic health record system integrating all of the health professions, then the derivative question, the second order question is, can all of their equipment rapidly and seamlessly feed into the systems that we buy? That's a much, much bigger question, and we'll get to it as soon as we finish going live.
Thank you, Carl. Coming back to Howard, and let us talk a bit about the patient perspective. What is different about the patient experience when EHR is implemented based on your global experience in these EHR implementations in multiple healthcare organizations?
Well, I think there's a few things that the patient can get out of this and reap the benefits of. First of all, just the fact that the patient care that they're receiving is better organized should result in less waiting time for things, should result in better care, less mistakes. But in addition, the overall goal is, of course, as Carl said, not only to help the patient when they do have problems, but do some amount of preventative care to make sure that we catch things in the bud. And modern systems, particularly our system, have what we call patient portals, the ability for the patient to gain access to their own medical records. There's a whole philosophical point about the data that is collected by the healthcare organization. Who does it actually belong to? I'm of the opinion that it actually belongs to the patient, that the healthcare organization really is just the caretaker of that information. So by having that all organized in one place, giving the patient the opportunity to have it, to distribute it as they want, to protect their privacy when they need the privacy protected, but also to be able to enter data, to do some mundane things like scheduling appointments and getting refills on prescriptions, but more importantly, to be able to communicate with all the various healthcare providers in a much more efficient manner. I think it creates a much better experience for the patient, both in terms of comfort and more importantly, in the actual care that they get.
Thank you, Howard. It's very, very interesting. So coming back to Arsalan, given the challenges that we have discussed and the risks associated with the change of any sort, the case for implementing any transformation project can be complex and vary by organization. So can you share your perspective on the short-term and long-term business case for committing to high investment technology projects like EHR or any other big high investment project?
Sure. So some of the things have already been discussed in terms of the business case. And before we get there, I'd like to, I guess, emphasize on the fact that when we are thinking about capitalizing on the digital transformation and the benefits that come out of digital transformation, it is essential that we get the foundations and the collaborations right. So when I refer to foundations, I mean having the right people in place that you and Dr. Kal already touched upon. Looking at the cost considerations of not just the licensing, but also the infrastructure, the implementation, any enhancements in the future in terms of any reports or any AI or machine learning capabilities that you might not have foreseen initially, but the practice demands in the future. Having the proper hardware, the backups of the data, ensuring the privacy, confidentiality of data, so things like that, having the right foundations in place, and then essentially having the right collaborations in place where if the goal is interoperability, then how do you ensure at least the first thing, at least your organization and different areas in your organization and different hospitals or clinics within the country or even across the globe, they are talking to each other. And then how do you ensure that your entire organization is talking to another organization and getting the data back and forth. And then we have to talk about integration with legacy systems that are already in place, or the back office systems, be it your HR systems, your financial systems. So how does the data then talk between the two systems? So those are, and then another collaboration is the patient, a collaboration between the patient, the system, and the institution. So training the patient to essentially ensure that patient is aware of all the tools and all of the features of the service that is being provided through the IT system or the app that is being provided, and that the patient then essentially uses it. For example, for booking an appointment or for filling out their data when they first come into the clinic or the hospital. So these are some of the things. So ensuring that the foundations are in place, ensuring that the collaborations are or will be in place. When these two things go hand in hand and are ensured, then we can then talk about the capitalization part and the benefits part, which essentially have some of which have already been covered in AI and machine learning and in better patient experience in terms of lower waiting times. In terms of so one of the bigger things for I guess any healthcare setting or healthcare provider is as the so our biggest provider is a consultant who essentially makes a name for himself and has a following of patients. So then how do you ensure you optimize their time? So by providing him with patient data beforehand, and by providing him the proper tools, you can then ensure that the quality of conversation he has with the patient is much improved, and the chair time that he's giving to the patient is reduced. So essentially, he can then see more patients. So considerations like this, I guess, in the longer term, then make way for and justify the intensive and the high cost initially that would be outlaid on such a system.
Thank you, Usman. We have discussed, of course, about the challenges of hardware, human capital, and then the motivation behind investing in these high-end projects. And Howard already shared with us about actually what are the benefits for the patient safety. But of course, the biggest part here is that we need all these things, but financial is an important factor here. So Carl, can you tell me a bit more about the financial challenges for such high investments?
The installation of Expanse is the largest non-building project AKU has ever undertaken in its 40-year history. It's a very large sum of money, and It's the nature of the project that we have not been able to attract philanthropic support for the installation of the EHR. So it comes 100% out of operating. When we build the building, you can put your name on the building. We have been very successful in getting at least 75 and sometimes 90% of the cost of all of our buildings covered by wealthy individuals, international development agencies, and on and on and on. For this project, which is more expensive than a number of our buildings, we were on our own. So it's a major reorganization over many years of operating funds, flexible capital at the end of the year, and so on. So that's the first point. I mentioned that currency fluctuations are part of our everyday existence. That's true. But since the pandemic, we have not seen the up and down, we've only seen the down. And any of you that follow the rapid arrival and departure of senior government leaders in Pakistan, you know that that's disruptive on the currency markets, and we're testing new lows. So with this large capital investment, there's dislocation. The other piece, and this is a bit of a lessons learned, we assumed, having never done this before, that we would be able to sort out our workforce, both running the current system and installing the new system. In other places, my experience in Canada, you hired a shadow workforce to run the current place while the permanent people are away learning the new system. I'd be cautious about assuming that your current employees can do both. And that creates yet another financial stress on the operating accounts. And my last piece of advice, and I say this with all sarcasm and flippancy intended, just do not plan to do this during a pandemic. That's a really, really, really bad idea. Our colleagues in Meditech couldn't travel. Our colleagues in Karachi couldn't travel to Kenya. Nobody could travel. And yet we were still working to install, to make the changes needed. So that has created a certain financial stress, but I can't point to the EHR project for the pandemic. That would be way over the top. But those are some lessons learned from an LMIC perspective, especially the piece about assuming your workforce can do both. You're just going to have to bite the bullet, pay the price, and supplement, my opinion. Thanks.
Thank you, Carl. It's very, very interesting. And so coming to Howard, implementing EHR is at the interface of many departments within an organization. Collaboratively working is hard and of course, the best of times. What advice can you offer organizations exploring the implementation of EHR to empower all stakeholders to contribute effectively to such a project, based on your experience in interacting with many, many organizations? Can you just unmute yourself, Howard?
Sorry. Yeah, that's a great question. And in fact, the key to a successful implementation is getting that exactly right. It's empowering the right people. You know, it's usually not the senior management who is an issue, and it's usually not the junior staff who's an issue in doing this. It's really the middle management of an organization, and particularly healthcare, that has become accustomed to the way they do things, and management is coming in and saying, here's a new system. We find that we really have to get the cooperation of the middle managers, the department heads and the assistant department heads, the ones who know their system, they know the people, and get them to accept change. Seeing the involvement and the commitment of senior management is maybe the most important thing. I always say, when I call up the CEO of a healthcare organization and leave a message, if the CEO doesn't return the call, but has the CIO return the call, I know there's a problem, because it doesn't show the commitment of the organization. Happy to say that's not the case with Aga Khan. Carl is very available and very involved, as is the CEO of the whole organization. But that's something that's got to be worked on, the commitment of the organization. There's a big morale factor that's involved in this. People want to resist change. There's a lot of work. Carl pointed out the challenge of getting your normal work done. I always tell our staff that we have the luxury, the only thing we're doing is implementing the system. Our customers have to implement it, but they also have to take care of sick patients at the same time. So there's a lot of challenges and a lot of planning that has to be done, and a lot of working on the staff to keep the morale high and make sure that they understand what the long-term benefits of this hard work up front will be.
Thank you, Carl. And I have been actually informed that we have just a few minutes. So I will just ask the last question to you, Howard, and then the same question goes to Carl and Arslan afterwards. So what would be your advice based on all this discussion? Of course, many companies, many healthcare companies are listening to this. What would be your advice about preparing towards EHR? What are some of the key things they should be considering while they are planning about going towards EHR?
I think keeping your eyes on the basics of what you're trying to get done. There's a lot of advantages once the system's in place. You know, Carl talked about potentially developing machine learning algorithms to screen patients and find out patients. That's great, and we want to get to that, but you really have to concentrate on the basics of how are we going to get paid for the healthcare we do provide? How are we going to fill prescriptions? How are we going to reorganize the tasks that we have? Make sure that the clinicians are on board and really understand that there's always some resistance from physicians in some of these systems. It's not as bad as it was 15 years ago. I haven't heard over my dead body in a while from a doctor, but they're still resistant because there's more work for the doctor up front. So really carefully demonstrating the system, showing what the benefits are, making the staff part of the process of selecting a system is, I think, the key to making this happen, which again, really makes them more committed to the whole process, rather than viewing this as something that's being imposed by senior management.
Thank you, Howard. And then I will just take the same question to Carl. What would be your experience, Carl, with your broad experience of implementing EHRs in North America, Canada, here in Pakistan? So what would be your advice for other institutions to think about?
Agree completely with Howard's list as it relates to EHR. In 1995, I was part of a team that introduced SAP in a Canadian university, and then I did PeopleSoft, and then I did the EHR, and then I did wireless, and now I'm doing EHR again. So what I'm about to say is not specific to EHR, and I call it watch out for disguised fear. Universities, hospitals, healthcares, they're filled up with many, many very, very, very smart people who are not generally willing to admit that they can be afraid of anything. So you walk into a room and you introduce EHR, and immediately you get the list of reasons why this is a really bad idea, it can't work, you don't understand us, our patients won't accept this, and on and on and on. And in my experience over several big system installations, when you peel it all back and there's a distinct age profile, they're just afraid. They don't want to have to learn yet another system because the last time they did it, they looked like idiots, and they don't want to have to look like idiots again. So watch out for disguised fear. And if you have a room full of physicians and you start talking about a new EHR system, in my experience, there's a very clear age profile. The younger generations, I can say this because almost everybody's younger than me, they just want to get on with it. Like, well, what's taking so long? Finally, you're going to help us help our patients. People that are 55, 60, and that's a growing cohort in healthcare, they just don't want to have any part of it. They want to do things the way they always did. They know in their heart this is better, but at the end of the day, they know they're going to look like incompetent people until they master it. They just don't want to do it again. How you get over that? That's the secret to success. We're largely over it, and we did it by endless communication, hand-holding, talking, cajoling, And there's no shortcut. You just got to bring them along, but you also have to do it. If you don't do it, then you're not serving your patients well by keeping things in a disorganized paper environment. Thanks.
Thank you, Carl. And Arslan, your thoughts?
So from a Pakistani perspective, first thing is innovation is nothing without execution. But having said that, it is essential and vital to keep it simple. When we talk about digitization and transformation, we talk about all these innovative and think about all these innovative solutions, but we have to ensure that they're practical. So my advice and recommendation would be start small, digitize your day-to-day, and then go above and beyond. And the second thing would be don't shy away. Yes, the cost considerations are high. Yes, there is going to be a lot of change management involved. But this is the way forward, and this is the only way, in my opinion, that you will be able to essentially compete in the future, where your competitors or other organizations. So this is a new age where healthcare institutions essentially in the future will have to then compete for patients. And in the past, that wasn't the case. And so to be able to compete for patients, you have to provide better solutions, better patient outcomes, better patient experience, et cetera, et cetera. So don't shy away from it. Keep it simple and start small, start somewhere.
Thank you, Arslan. I would have loved to continue this discussion for another hour or two, but I think we are tight with the time, the overall allocated time. So thank you, Carl, Howard, and Arslan for your candid discussion of the challenges and lessons learned from your experience. As we undertake this journey at the Aga Khan University, it is so powerful to know that we have the opportunity to build upon the insights shared today to help our implementation to progress with the greatest opportunity for success. Evidently, EHR actually is the way the world is going. Our best challenge is charting a path that is comfortable, effective, and delivers the impact we all seek. Ultimately, for the patients who access our healthcare services. So thank you very much, everyone, for your time. And then thank you to all the attendees who are listening us, and over to Kamal and Saki. Thank you all.
Take care. Thank you, everybody.
Take care. Thank you.
Thank you.